In the emergency department, we see a lot of patients who come in with suicidal ideation. It's always useful to have a psychiatrist around to help us determine who can stay, who can go home outpatient. But sometimes you don't have access to a psychiatrist. So, to discuss how we think through these issues from the point of view of a psychiatrist in the emergency department, my guest today is Dr. Andrew O'Hagan. He's a clinical assistant professor of psychiatry at NYU. Thanks for being here.
Thank you for having me, Dr. Mitra. So the most common presentation of a behavioral patient in an emergency room is usually suicidal ideation. And we'll sort of, next few minutes, sort of unpack how we assess psychiatric risk.
That's great. Yeah, because I think, for us, this is very intimidating. If someone complains of suicidal ideation, we feel very uncomfortable sort of making a call on that, whether they need to be held or can be discharged. So yeah, I'm very excited to hear sort of how you think through this and how you go about making those tough decisions.
So step one, mandated by the Joint Commission, is there is a screening tool for suicidal patients. It's called the Columbia Suicide Severity Rating Scale. And it has some problems, but it really is a tool that is used to assess in real time someone's current level of suicidal ideation compared to a cohort of patients that all may have suicidal ideation. Are you experiencing one point for something called passive suicidal ideation? This is a thought, a wish to die, or morbid thinking, but there's a difference between passive suicidal ideation and active suicidal ideation, which is, at that point, it's, passive is 1 point on the scale. The minute you get to active suicidal ideation, it's 2 points.
And when you say active, you mean sort of a plan, like I would imagine doing this particular act.
Not necessarily. That's the next question. Active suicidal ideation is not just a wish for death, but a wish to actively kill oneself.
I see. Yeah. So passive might be, I just sort of wish I wasn't alive, versus active might be, I actually wish I would kill myself.
Yes.
Okay. I get that.
After a patient says, yes, I'm thinking about killing myself, then the question becomes, is there a plan? And there's a difference between method and plan. Method is 3 points on the scale. Patient says, I'd like to shoot myself. That could be method or that could be plan. The difference between method and plan is the patient says, I will go to the particular sporting goods store in upstate New York, where it's easy, in upstate New York, there are more legal gun owners. And I know that there is a waiting period and a background check. And in the meantime, I'm going to learn how to operate a firearm. That's a developed plan.
I see. Okay. So a method is sort of saying, I've had a patient that says, I'm just going to jump in front of a train.
Yeah.
But a plan is, there's this train that is going by tomorrow at this time, and I plan to sort of leave my house at this time and go there. That would be a specific plan.
Yeah. Or another example of this discrepancy between method and plan can be the patient says, I'll overdose on drugs. And then a more detailed question, what drugs would you overdose on? The patient says, well, I know that if I take a bottle of Tylenol, that will shut down my liver and maybe kill me. That's plan as opposed to method.
As from my perspective, this may be just an amateur way of thinking. I'm sometimes afraid to ask patients that because it almost sounds like I'm egging them on. If they're saying, I want to jump in front of a train, and then I say, well, which train? What time would you do it? It's almost like I'm sort of pushing them to come up with a strategy for something really horrible.
I think that's what's difficult about this screen and interviewing psychiatric patients is that the clinician has to work in open-ended questions and closed-ended questions. So sometimes there are moments where very close empathic listening is more important as to what the patient says versus other times where you're sort of forced to ask closed-ended questions.
Okay, so we discussed method and plan. That makes a lot of sense to me. What's next on the scale?
So at this point, again, this is a 5 or 6 questionnaire. So we've addressed 4 of those 5 questions. The 5th thing to ask is there anything that would prevent you from having a suicide attempt? And it speaks to intention. And the patient will say, either say, well, no, there's nothing that would prevent me from having a suicide attempt, which is, again, a sign of severe acute mental health emergency. Or they'll say, well, I have these feelings and thoughts, but I have to take certain things into consideration, how this would affect my family, my friends. You know, does this speak to my ethical or religious beliefs in any way?
Or maybe I have a dog at home I need to take care of. I could never leave my dog alone.
Exactly.
Okay. So that's that Columbia scale. Is that all we really need to assess the risk here, or is there anything more to it?
There are some issues with the scale because the scale only addresses what's going on in real time from the moment they hit an acute care facility. One of the things to sort of assess is recent suicidal ideation before the hospital, and were there behaviors that were concerning, self-harm behaviors, an aborted suicide attempt, a frank suicide attempt. There are some institutions where they'll ask the patient, well, okay, they score a Columbia Suicide Severity Rating Scale in real time, but how high was your score in the last 30 to 60 days?
Oh, interesting. So you're saying this is a snapshot in this moment, but it matters whether this is something that's just been going on for a day versus 30 days.
Yeah, because it's hypothetically a patient can score 0 or 1 when you're seeing them, but a few hours earlier or a few days earlier, their score may have been a 4 or a 5.
Well, how do you get to the bottom of that to sort of assess what was going on in the past?
Well, on my end, I will ask, like, how intense are these thoughts, intensity and frequency of the thoughts, and then the character of the thoughts. When was the last time you had a plan and strong intent? That's a natural question to sort of ask.
And if they had had a plan yesterday, that's more risky than if they had had a plan a year ago? Or, I mean, how do you interpret sort of what they answered?
Well, I'm always more interested in recent behavior. That said, as a segue, prior behaviors often dictate future behavior. So, if this person has a lifetime history of a suicide attempt in the last year, that is an important piece of information. And understanding the frequency and severity of prior behavior.
Okay, so the more frequent the behavior, the more risky it gets.
True. And
I could understand it. I could imagine a scenario that would go the opposite way, is where I sort of get confused, is if someone's sort of making these complaints many times over the years, you almost take this one less seriously because they haven't done it in the past, or is that not the right way to think about that?
Well, as a separate issue, there are a subset of patients that use the ER and are aware that if they say they're suicidal, that they have to have a full assessment. But context matters. The things that I am attuned to, and when I read an emergency medicine physician or a clinician's notes, if someone had a suicide attempt, what did their medical clearance look like? Did they have to be medically admitted or admitted to an ICU? That speaks to the severity of the attempt. Again, I like personally reading the notes from toxicology. Were there objective signs of an overdose? If someone is a cutter, where did they cut? I like to read procedural notes. How many sutures were put in? Was there any important anatomy that was close to where they cut?
What I'm getting from this is sort of, that scale that we talked about is pretty objective. But when it comes to assessing this historic risk, the more attempts, the more intentions there were in the past, and the more serious those attempts or intentions were, raises the risk. Is there an objective sort of scale-based way to assess this, or is this more of a gestalt that you've sort of developed over the years?
I would say a gestalt. And, again, a psychiatrist has more time to invest in teasing this out with review of records and interviewing a patient. We're looking at the totality of the patient, not just the recent behavior, but how prior behaviors may influence future behavior.
Okay, so where do you go next with this information? What else do you want to know?
Well, on our end as psychiatrists, we spend a lot of time dealing with collateral. So there's the patient report and the observed behavior. And the patient report may include a listing of mood symptoms, psychotic symptoms, anxiety symptoms, substance use issues that may come up. But we spend a lot of time reading charts because the patient is giving a narrative, and it may not be an accurate narrative. So there's a lot of time with review of records, ideally looking at certain databases that we use in psychiatry, at least in New York State, and also making phone calls if possible. So speaking to family members and outside providers. So, we spend a lot of time with our assessments trying to pull all this information together to make a clinical opinion.
So you might find that the family member is saying something that's potentially making you more worried or potentially making you less worried. So you want to get that third party, objective outside observer in there.
Yes.
Okay.
Because patients either sometimes they frankly don't tell the truth, but a lot of times they distort, and there may be other issues going on in the assessment. I want to sort of step back to talking about the intoxication and substance use. So if you have a patient that has a primary psychiatric diagnosis and they're abusing substances, even if they are not physiologically intoxicated, most substances have a disinhibiting quality. So again, it's not uncommon in an emergency room, a patient may have suicidal thinking in the context of substance intoxication. And that's also something to be worried about. And that is a risk.
So what do you do with that? Because we see that all the time. Someone's intoxicated and they make suicidal threats. This can be anyone from a college kid to someone who's, living on the street. I mean, do you disregard what they say because they're intoxicated? Do you take them more seriously? How do you assess that?
This is sort of controversial because there's, psychiatrists often get caught in this paradigm where they write things in charts, hold for metabolization of substances. But in terms of good clinical practice, a psychiatrist should be thinking about how long is the toxidrome for this. If we hold someone indefinitely, they may start to withdraw. I usually give an intoxicated patient, and this is, again, anecdotal and not evidence-based, I usually give patients 3 or 4 hours to try and sober up and to be observed. The problem with holding someone indefinitely.
I'd rather get the history and assess them in a more sober state.
Yes.
And if they, in a sober state, sort of go back on whatever they were saying when they're intoxicated, does that sort of negate? Do we just say, okay, well, you were drunk, it didn't really count for anything? Or how do you assess that?
Again, this is where building the gestalt is important. They had suicide attempts when they're sober. Again, that's a judgment call from the psychiatrist, but the more information that we have from both patient interview and from clinical collateral, the chart history, the better that we can make decisions.
It sounds like you're taking in a lot of information and using a lot of nuance and a lot of experience to sort of come to a decision. Maybe you could sort of talk about what we can do as ER practitioners in the emergency department to sort of help you guys on that journey.
I think emergency medicine, like emergency psychiatry, is a team sport. I think from an emergency medicine standpoint, asking direct questions is not a bad goal to set. So a patient comes in with suicidal ideation, again, the ER doc should ask, well, was there an attempt recently? Or what they call an aborted attempt, like you got close and you changed your mind, someone stopped you, and has it happened before? Well, the patient may say, well, it happened 5 years ago. And then the details of what happened, like was it require that complex medical care in a hospital, that's important to know. That helps us guide treatment once you involve psychiatry. Like we get a sense quickly, how sick is this person? Again, and that helps a great deal.
What tips do you have for us in terms of how do you weigh the importance of maybe the scale versus the history versus collateral versus substance issues? How do you weigh all that together to come to a final point of making this binary decision of keep or discharge?
Um, well, we have a third option. We have, hold. Um, I no, I think it's important for clinicians to feel confident in their decision making. But sometimes you don't have enough information in real time to be able to make that type of decision. I, what I tell training psychiatrists and also my colleagues in emergency medicine is trust your instinct. ER psychiatry is not an exact science. I'm not in the business of being able to tell the future. If I would be in Las Vegas as a clairvoyant if I could do that.
Right.
Um,
Yeah, you wouldn't have to have this job.
yeah, we're taking a best guess. But the stronger the sensitivity for making a clinical decision is directly related to the quality and breadth of information that we have. And I think there's something to be said for trusting your instincts and trusting your gut. And we live in a world where data is freely available. So you can look people up all the time, where we can see old notes from other institutions. But I would say, again, for ER docs and for psychiatrists, if someone looks sick or is not forthcoming, you want to err on the side of caution. All of this is about making reasonable decisions.
Well, this is super helpful to hear. I mean, there's so much that goes into it. I'm not sure, like, I don't think there's some simple way for us in the ER as medical folks to make this call, but it is really insightful to hear how you sort of think through this and all the different components that you weigh and how you sort of weigh them. So thank you so much for your time.
You're welcome.